How much of your day is spent sitting? What if I told you there's a disease that makes it almost impossible to sit? What if I told you that has nothing to do with your muscles, that you'd be perfectly capable of sitting, standing, walking, except yet you'd still choose to experience the rest of your life completely in the horizontal position? What if I told you that this disease was caused by something as innocent as yoga? As beneficial as yoga can be, there are some dark secrets that no one really talks about. From sex cults to torn ligaments to one mysterious and often misdiagnosed syndrome that, if left untreated, can result in massive and permanent brain damage. In today's video, I walk you through the story of Sam, a 38-year-old woman who, after yoga class, develops debilitating headaches that leave her completely bedbound and eventually comatose. Sam's case is based on several case reports published in the medical literature. Stay tuned until the very end of the video to learn what this disease is and what you can do about it to avoid her same dark fate. If you like hearing about the many ways our fragile bodies fail, then please subscribe and hit the notification bell. I'm a board-certified doctor and hope to bring you interesting medical cases to make you squirm, laugh, jump, and cry. Sam, a 38-year-old woman living in California, is a vibrant and bubbly individual. Most who meet her immediately take a liking to her naturally sunny disposition. Like most people in the Bay Area, she works in tech and often follows the next new hot health trend promising immediate energy and vitality. From juice cleanses to freezing showers to intense 5 a.m. workout routines, Sam finally found something that clicked for her: yoga. She was naturally flexible and had long arms and legs that worked well for the odd contortions this practice demanded of her. Today, in her favorite studio, she was working hard to impress the instructor who she had developed a crush on. In a soothing voice, he tells everyone to push for another minute, and Sam does so with renewed determination. That is, until she hears a sickening pop in her upper back and neck. The immediate shooting pain causes her to collapse onto the mat. The instructor rushes over, but with her ego on the line, she downplays it and just says she's just fine. Thinking she tore something, she heads back home to rest, pops a few painkillers, ices the back of her neck, and goes to bed trying to forget the sickening pop she had both heard and felt. The next morning, she awakens with a slight headache but tells herself that is nothing she hasn't experienced before. Feeling hopeful, she gets up to start her day, but in doing so, she feels the headache immediately start to worsen. The day progresses, and Sam's headache steadily worsens as well. Sam is beginning to get unnerved and wonders if she should go get checked out. She's had her fair share of headaches in the past, but this one just felt different. She checks into an urgent care. Without any red flags in her exam or story, the clinician concludes that she likely pulled her trapezius muscle or the other tinier muscles in her neck and upper back. Either way, the conclusion was that it's not a big deal. She is given an injection of pain medication and sent home with a prescription of muscle relaxers. She didn't have time to dwell on the issue because it was crunch time at work. Her coworkers were depending on her to get a new software running, and the sooner she could finish it, the sooner the project would move forward. Trapped in her apartment, feverishly coding the late hours of the night, she begins to hear strange noises throughout the apartment. Because it is almost imperceptible, she chalks it up to exhaustion and decides to ignore it. By the time she collapses into bed, the sound abruptly cuts off and all is quiet again. The second night is even worse. Sitting in her favorite dark leather chair alone in the darkness, illuminated only by the computer monitor in front of her, the eerie sound is clearly back and is now reverberating throughout the apartment. This time, because it is louder, she can hear that it sounds like coarse static. Almost as if someone had turned on an old-fashioned radio and is angrily flipping through its stations. The pain pounding in the back of her head makes it hard to concentrate. Wait, is someone actually there? Nah, she brushes away the thought as she continues to code. Unconsciously, she sits up straighter in her chair and shouts out to no one in particular, "Hello, baby." Her headache worsens with this maneuver. Without missing a beat, the ambient static noise abruptly gets louder too, almost as if trying to respond. Sam stops typing mid-sentence. It has her full attention now. Holy crap, they can hear me? What is going on? Her eyes are still glued to the bright screen as she thinks through the situation. Did she remember to lock the door or the window? The latch is easily jiggered open. She slowly sits up even taller now, trying to peer above her monitor. In response, her headache worsens yet again. She has no time to process the pain as something appears to dart away in her peripheral vision. Horrified, her eyes involuntarily dart in the same direction too, forcing an unwilling Sam to visually give chase. Luckily for her, the afterglow from staring at the computer screen for the past few hours has effectively killed her night vision, temporarily saving her from confronting her worst fears. Clearly spooked, her only desire in this moment is to turn on as many lights as possible and see what is going on. She abruptly stands to full height, but in doing so, her headache now jumps to maximum intensity. Timed perfectly, the static noise is likewise boosted to near deafening levels while the room starts spinning like a high-speed carousel. Her tentative step forward is aborted as she realizes she has no sense of direction in this sensory frenzy. Legs now made of jello, she loses her balance and falls. Catching a glimpse of the bed 1 foot away, she instinctively throws her body towards its direction mid-step. Success. She lands into bed and pulls the covers over her head like a little kid, covering her ears with her hands to drown out the thunderous noise making its way towards her. She knows for sure someone is in her apartment. Helpless, all she can do is hold her breath. She counts. 1, 2, 3. Hello everyone, hope you're liking the story so far. Just wanted to interrupt and bring you a word from one of our sponsors. Oh wait, that's right, we still don't have any sponsors. So please, do me a favor. If you like the story so far, please don't forget to like, subscribe, share, and hit the notification bell. Okay, now back to the story. At the end of the third count, she braces herself for the worst, but as suddenly as it all started, everything is quiet again. She peers shyly from behind the covers and sees just an empty leather chair illuminated by the faint glow of her computer screen. And the living room? Just as she left it. Even the headache has dialed itself back down to tolerable levels. Exhausted, she collapses into bed once more and promptly falls asleep. The next day, she wakes up in a panic, realizing her big project is due today. She's not sure what happened last night, but chalks it up to working too hard. She jumps out of bed and plants her butt right in her favorite leather working chair and starts coding again. She has 4 hours before she has to present this to her boss. She notices a curious feeling that she only processes much later in her journey. The moment she sits in the chair, the same oppressive feeling from last night overtakes her. The static noise, the ominous buzzing, the pounding headache, they all start converging in on her once again. But this time, with the bright sunshine streaming in, she sees that it is all clearly in her head. As she is more scared of losing her job than of any supposed paranormal activity, she soldiers on, finishes the program, and rushes to work in downtown San Francisco. Standing in front of the conference room, the headache is pounding with an intensity she has never felt before. She does everything she can to push through the presentation, but is beginning to hit a wall. On the last slide of the PowerPoint, she sees a jagged arc of bright lights in the periphery of her vision. That is the last thing she remembers before total and complete, utter blackness. Sam wakes up in the ER feeling groggy and confused. A concerned coworker next to her explains that while giving the presentation, she had collapsed to the ground and started seizing. Luckily, she is okay now, the coworker explains. The doctors didn't find anything wrong.
They are attributing it to overwork, since I told them that you were up all night working like a dog. We all know how important this project is to you.
The doctor prescribes Sam an anti-seizure medication called phenytoin and instructs her to follow up with the neurologist in a few days. Still in a state of shock, Sam can do nothing but nod in agreement. Does he know about my weird headaches? Before she's able to mention this, he leaves and she decides to drop the issue. Besides, lying there on the stretcher, Sam actually felt great. No headaches, no noises, no problem. She gets up from bed and sits in one of the chairs on the side of the room and begins to change out of her gown. But the moment she lands in the chair, the same ominous feeling from before overtakes her, and her movements begin to falter. Her coworker can plainly see that she doesn't look well and asks if she is okay.
Do you hear that?
Sam groggily stutters out. Once again, the thunderous static noise had appeared from nowhere and was quickly closing in around her while the ground beneath suddenly felt like a deck of a jostling ship at sea. Another arc of lightning flashes in the horizon before all was black once again. It appeared Sam was having another seizure and had collapsed to the floor yet again. The coworker cries out for help, and doctors and nurses rush back in to help poor Sam. She is lifted back into the stretcher while an IV is quickly placed into her arm. Multiple milligrams of a benzodiazepine is pushed into her bloodstream to abort this intracranial electrical storm. She is rushed to the CT scanner. The CT is done with intravenous contrast to highlight the sensitive blood vessels to her head and neck. While the ER doc was most afraid to find blood in the brain or tears in the sensitive arteries of her neck, what he found was neither. Instead, the CT revealed, quote, bilateral frontal-parietal subdural fluid collections with effacement of basal cisterns and diffusely enhancing meninges. In other words, there were curious pockets of fluid in both sides of her brain, substantial enough to squish the brain tightly together, while the delicate layers of the membranes covering her brain and spinal cord appeared to be inflamed, infected, or worse. The doctors could not explain what had caused these findings, but knew she was in critical condition. It stands to reason that with the brain so tightly compressed by the fluid collections, the pressure within her skull was likely astronomical. Without intervention, the pressure may continue to rise and crush the brain further to the point where it is forced out of the hole at the bottom of the skull where the brain connects to the spine. The neurosurgery team is called in for this emergency. The goal is to create a burr hole, or a de facto pressure relief valve. To do this, they literally have to drill a hole into her skull. Sam is started on broad-spectrum antibiotics and antivirals. Her head is shaved, and a drill bit is placed against the smooth scalp. The doctor takes a deep breath and begins. The skull table is violated, and the thin membranes underneath are dissected away, revealing the fluid collection seen on the CT. Surprisingly, the fluid collection was not under pressure, and the cerebrospinal fluid sampled was not infectious. Confused, the doctor leaves to consult another colleague. Meanwhile, Sam is wheeled to the post-op recovery room. There, flat on the stretcher, she curiously begins to improve. A few hours go by and she is clear-headed and speaking once again. The nurses hoist and reposition her body with the head of the bed elevated at a 60-degree angle as a standard procedure for presumed elevated intracranial pressure. She is left to her own devices until about 30 minutes pass. The alarm bells begin to scream on Sam's monitor. The nurses investigate and realize that Sam's heart rate is beating incredibly slowly. She is lethargic and only able to stutter in gibberish. Fearing the worst, the nurses page out an alert over the loudspeaker and the rapid response team rushes into the space. Sam now has pinpoint pupils. Afraid her brain is being squished out of her skull at this very moment, the team sedate and paralyze her, insert a breathing tube into her trachea, place her on the ventilator, and rush her to the CT scanner once again. The repeat CT scan this time is read as diffuse cerebral edema. In other words, her entire brain is swollen and inflamed. The doctors aren't exactly sure what the culprit is, but hypothesize that Sam's immune system is attacking the blood vessels of her brain in a disease known as cerebral vasculitis. The inflamed vessel wall can block the flow of blood and cause strokes, major headaches, and seizures. Thus, a new treatment course is pursued and a brain biopsy is planned to confirm the diagnosis. Sam is given a course of high-dose steroids, cyclophosphamide, an immune suppressant medication, and mannitol to pull fluid from the swollen brain cells and reduce the intracranial pressure. Another hole is drilled into Sam's skull for the biopsy, and brain tissue is removed for sampling. Interestingly, no signs of inflammation or infection is found, nor is the brain yet again under any pressure at all. There is some thickening of the delicate membranes covering the brain, and most curiously, some signs of both fresh bleeding in the brain and apparently some old. The official name of the bleed is a subdural hematoma, a pooling of blood beneath the outermost membrane covering the brain right below the skull. But this is not the primary cause of the patient's symptoms. It simply appears to be a consequence of something else. More sinister. What in the world is going on? The doctors are indeed puzzled. All the diagnostic findings thus far have pointed to different things. The initial CT showed fluid collections, apparently compressing the brain with resulting inflammation of the brain membranes. The second CT showed worsening swelling throughout the brain and further concerns for high pressure. And yet, in both cases, when doctors do get down to the level of the brain, no signs of high pressure are found. Instead of inflammation or infection, the doctors find bleeding instead. What is causing the brain to bleed? What is causing the brain to be so swollen? To answer these questions, the doctors decide to do two last things. One is to get an MRI, the highest resolution picture possible, and two is to implant an intracranial pressure monitoring device. The doctors drill into poor Sam's skull a third time and implant this device. Consistently low pressures from 4 to 9 are definitively measured, proving that Sam's brain is not being squished and compressed by high pressure, but by low pressure? How does that work? It all finally makes sense once the MRI comes back. It reveals two things. Number one, bilateral small subdural hematomas, the brain bleeds that were already known. And number two, the ventricles of the brain, the inner spaces of the brain that are normally filled with cerebrospinal fluid, were being compressed down, and there was an obvious sagging of the brain into the base of the skull with compression of the diencephalon and impending herniation. In plain language, the brain was coming out of her skull, but is not being pushed out of the skull by too much pressure, as the doctors had initially feared, but was actually slipping out of the skull due to the lack of pressure supporting the brain in the skull. And from all that slipping, squishing, and friction, the brain was accidentally ripping itself apart and bleeding as a result. Have you heard of the brain in a vat hypothesis? It's the idea that we may be nothing more than brains floating in a jar connected to a supercomputer feeding us signals to generate the reality we perceive. While no one can disprove that theory, on a technical level, we are just brains floating around in a jar, except that jar is made of bone and conveniently sits on top of our necks. The liquid in our skull jars is a clear juice known as cerebrospinal fluid, also known as CSF. It serves many functions, such as providing nutrients and removing waste products, but one of the most important functions of this liquid is to maintain brain buoyancy. Just like a jellyfish collapses into a pile of gelatinous goo the moment you take it out of the water, a brain will do the same. Without enough CSF, the brain sags and collapses in on itself, crushing the delicate, sensitive structures within, and sometimes results in brain damage and massive bleeds. The name for Sam's diagnosis is intracranial hypotension. Because this condition is commonly overlooked, it remains gravely underdiagnosed. But it all makes sense now. The popping sensation she felt in her neck and back during yoga was likely the tearing sensation of the delicate membranous coverings of her spinal cord and brain, and through that tear, a slow leak had sprung, allowing all of her brain juice, or CSF, to leak out. A sagging, collapsed brain will cause major headaches. The nerves, connective tissues, and membranes of several sensitive areas in the brain are placed under great tension. The cranial nerves of the brain controlling vision, hearing, and balance are sometimes most affected. Some areas are being crushed, while other areas are being torn apart. This likely explains the strange auditory and visual hallucinations she had, and also likely explains why Sam tends to get better when she lies down and worsens when she sits. When Sam is upright, the full force of gravity is applied, threatening to suck her brain out of her skull, whereas when Sam is flat, gravity pulls her brain back into her skull instead. Does that mean Sam is destined to live a horizontal life, forever locked in the napping position? To fix this, the ideal solution is to find where the leak is and to plug it up. Imagine a deflating tire. When the leak is less than a few millimeters in size, it can be very challenging to locate. Now imagine trying to find that leak in the delicate membranes covering the human brain spinal cord system, when the entire thickness of those membranes are less than 1 millimeter in size. So, what do you do then? Cut open someone's back and analyze the entire spine square inch by square inch? Do you use a high-powered microscope until you see a tear and then dab it with a little bit of Elmer's glue? That would be insane. Luckily, the first step to treating a leaking brain spinal system is much less invasive, though not backed by a lot of hard evidence. Some say that wearing an abdominal binder will help regulate the CSF traveling through the spine. Others say to drink more water to help replenish their CSF stores. In the ER, caffeine is directly injected into the bloodstream with the hypothesis that this will stimulate more CSF production. To get instantaneous relief, however, you still have to physically plug up the leak. There's a technique known as the blood patch, in which 20 milliliters to 100 milliliters of your own blood is directly injected into the tight membrane surrounding the spinal cord. No one really understands how it works, but it's thought that the blood will travel throughout the spinal system and naturally deposit itself into the tear, creating a plug in the same way blood clots and fixes cuts on your skin. And that is what the doctors do for Sam. A fresh vial of blood is taken from Sam's arms. A long spinal needle is delicately inserted in between the hard vertebral bones of the lower back until it is felt to be in the correct spinal space. The 20 cc's of blood are subsequently injected in one fell swoop. The whole procedure takes about 5 minutes, and literally within 15 minutes, Sam is back to normal. Now alert and communicating with her family for the first time in what seems like ages, she is able to sit without an ear-splitting headache or hearing static noise. Never again will she take for granted her ability to simply just sit. And while this case has a happy ending, the journey to get there was indeed a nightmare. To think, Sam had a hole drilled into her skull, biopsy samples taken from her brain, medical devices implanted under her skull, a breathing tube choked down her throat. Realize that all of this could have been avoided if this simple 5-minute procedure had been done at the very beginning. If only someone had picked up on the fact that her headache seemed to only get worse when she was sitting. Sometimes it's the simplest and most subtle of clues that make the difference. Intracranial hypotension affects 1 out of 20,000 people. The average patient is 43 years old, with 63% being women. Possible risk factors include connective tissue abnormalities, spinal problems, back problems, and weight loss surgery. There are 2 takeaways from this story. Number 1 is to stop doing all yoga, Pilates, stretches, or other similar exercises. In fact, don't even think about exercising. Do not ever turn your neck or use your neck at all. Period. To ensure this, you must wear a neck immobilizer and back brace at all times. To be extra safe, you might as well not move. Studies show that wearing a straitjacket and pouring wet concrete into your pants and shoes can help with this. This way, you ensure you will never tear something in your spine, and thus will never spring a leak back there. And the second takeaway is to like, share, and subscribe. Studies show that hitting the subscribe button makes you 2 times more good looking. Okay, my friends, until next time, stay humble, stay healthy, stay fresh.
Peace.